Hello everyone and welcome back. My name is Dr. Ben Osevwe, DNP-PMHNP. Today we are starting a high-yield ANCC PMHNP board review series. This section focuses on lithium, one of the most tested and most important mood stabilizers you need to know for the PMHNP board exam. Lithium is one of those medications that the exam loves because it connects to so many topics: bipolar disorder, mania, suicide prevention, toxicity, thyroid monitoring, kidney monitoring, pregnancy risks, and patient teaching. So today we are going to review the question, read all the answer options, identify the correct answer, and explain the rationale in a clear way. Remember, do not just memorize the letter. Understand the reason behind the answer. That is how you pass the exam and practice safely. Let's get started. Question 1. A patient taking lithium for bipolar 1 disorder has a serum lithium level of 1.0 milliequivalents per liter. How should the PMHNP interpret this level? A. Subtherapeutic. B. Therapeutic. C. Early toxicity. D. Severe toxicity. The correct answer is B. Therapeutic. Rationale. The therapeutic lithium range is generally 0.6 to 1.2 milliequivalents per liter. A lithium level of 1.0 milliequivalents per liter falls within the therapeutic range, so this is an expected treatment level for many patients. Option A is incorrect because the level is not too low. Option C is incorrect because early toxicity is more concerning when the level rises above the therapeutic range, especially around 1.5 milliequivalents per liter or higher. Option D is incorrect because severe toxicity is usually associated with much higher levels, especially levels greater than 2.5 milliequivalents per liter. Exam Pearl. For lithium, memorize this range. 0.6 to 1.2 milliequivalents per liter is therapeutic. If you remember that, you can answer many lithium questions. Question 2. A patient on lithium has a serum level of 1.6 milliequivalents per liter and reports nausea and coarse tremor. What is the best next action? A. Continue lithium and recheck next month. B. Increase the dose slightly. C. Discontinue lithium and assess toxicity. D. Add benztropine. The correct answer is C. Discontinue lithium and assess toxicity. Rationale. A lithium level of 1.5 milliequivalents per liter or greater suggests possible toxicity, especially when symptoms are present. This patient has a level of 1.6 milliequivalents per liter, nausea, and coarse tremor. Those are warning signs. The PMHNP should hold or discontinue lithium and assess for toxicity. Option A is unsafe. Option B is dangerous. Option D is incorrect because benztropine is for EPS. Example: fine tremor may be a common side effect. Coarse tremor is a red flag. When lithium toxicity enters the room, do not offer it a chair. Stop and assess. Question 3. A patient taking lithium has a serum level of 1.4 milliequivalents per liter and no symptoms. Which action is most appropriate? A. Stop lithium immediately. B. Continue lithium and closely monitor. C. Double the dose. D. Switch to valproate immediately. The correct answer is B. Continue lithium and closely monitor. Rationale. A lithium level of 1.3 to 1.4 milliequivalents per liter without symptoms may be monitored closely. The PMHNP should assess for symptoms, review hydration status, renal function, medication interactions, and whether the level was drawn correctly, usually about 12 hours after the last dose. Option A may be too aggressive. Option C is unsafe. Option D is not necessary without further assessment. Exam Pearl. Lithium levels are not interpreted in isolation. Always ask, what is the number? Does the patient have symptoms? And was the level drawn correctly? Question 4. Which lithium level is considered a medical emergency? A. 1.2 milliequivalents per liter, B. 1.4 milliequivalents per liter, C. 1.8 milliequivalents per liter, D. Greater than 2.5 milliequivalents per liter. The correct answer is D. Greater than 2.5 milliequivalents per liter. Rationale. Severe lithium toxicity is typically associated with levels greater than 2.5 milliequivalents per liter and can become life-threatening. Severe toxicity may include confusion, seizures, severe tremor, ataxia, kidney injury, altered mental status, coma, and even death. Option A and B are closer to therapeutic/mild. Option C suggests toxicity, but D is the classic emergency level. Exam Pearl. Lithium greater than 2.5 milliequivalents per liter is a medical emergency. That is not a let's recheck next month situation. Question 5. Which medication is considered the gold standard for acute mania? A. Lamotrigine, B. Lithium, C. Sertraline, D. Buspirone. The correct answer is B. Lithium. Rationale. Lithium is a classic first-line mood stabilizer and is considered a gold standard treatment for acute mania and bipolar I disorder. Lamotrigine is for bipolar depression and maintenance. Sertraline can worsen mania. Buspirone is for anxiety. Exam Pearl. Acute mania and bipolar I. Lithium should be one of the first medications that comes to mind. Question 6. Which medication has strong evidence for reducing suicide risk in bipolar disorder? A. Haloperidol, B. Lithium, C. Carbamazepine, D. Benztropine. The correct answer is B. Lithium. Rationale. Lithium has well-established evidence for reducing suicide risk in patients with bipolar disorder. This is one of the most important clinical pearls about lithium. It is not just a mood stabilizer. It also has anti-suicidal benefits. Haloperidol, carbamazepine, and benztropine do not have this classic association. Exam Pearl. Bipolar disorder plus suicide prevention equals lithium. The exam loves this. Question 7. Which antipsychotic has evidence for reducing suicide risk in schizophrenia? A. Risperidone, B. Olanzapine, C. Clozapine, D. Quetiapine. The correct answer is C. Clozapine. Rationale. Clozapine is the antipsychotic most associated with reduced suicidality in schizophrenia. Clozapine is often used for treatment-resistant schizophrenia and has evidence for reducing suicidal behavior in schizophrenia or schizoaffective disorder. Other antipsychotics are not the keyboard answer for this specific benefit. Exam Pearl. Lithium reduces suicide risk in bipolar disorder. Clozapine reduces suicide risk in schizophrenia. Put those two in your high-yield memory bank. Question 8. Before starting lithium, which laboratory studies are most important? A. CBC and lipid panel only, B. Renal and thyroid studies, C. Liver enzymes only, D. Serum prolactin only. The correct answer is B. Renal and thyroid studies. Rationale. Before starting lithium, the PMHNP should assess baseline renal function and thyroid function because lithium can affect both. Lithium is cleared through the kidneys. Lithium can also cause hypothyroidism. Liver enzymes are for valproate. Prolactin is for antipsychotics. Exam Pearl. Lithium equals kidneys and thyroid. If the exam asks what to check before lithium, think BUN, creatinine, EGFR, TSH, and free T4. Question 9. Which thyroid abnormality is most commonly caused by lithium? A. Hyperthyroidism, B. Hypothyroidism, C. Thyroid storm, D. Graves' disease. The correct answer is B. Hypothyroidism. Rationale. Lithium commonly causes hypothyroidism. This may show up as elevated TSH and low free T4. Symptoms include fatigue, weight gain, cold intolerance, dry skin, and constipation. Hyperthyroidism and Graves' disease are not the classic effects. Example: lithium slows the thyroid down. So when you see lithium plus fatigue, weight gain, cold intolerance, and elevated TSH, think hypothyroidism. Question 10. A patient taking lithium develops fatigue, weight gain, cold intolerance, elevated TSH, and low free T4. What is the best interpretation? A. Hyperthyroidism. B. Hypothyroidism. C. Acute renal failure. D. Serotonin syndrome. The correct answer is B. Hypothyroidism caused by lithium. Rationale. The symptoms and labs are classic for hypothyroidism. Fatigue, weight gain, and cold intolerance point to decreased thyroid function. Lithium is known to cause hypothyroidism. Renal failure or serotonin syndrome would present differently. Example: elevated TSH plus low free T4 equals hypothyroidism. Add lithium to the question, and the answer becomes even clearer. Question 11. Which pregnancy complication is classically associated with lithium exposure? A. Neural tube defect. B. Epstein anomaly. C. Cleft palate. D. Limb malformation. The correct answer is B. Epstein anomaly. Rationale. Lithium exposure during pregnancy is classically associated with Epstein anomaly, a congenital heart defect involving the tricuspid valve. Neural tube defects are associated with valproate and carbamazepine. Cleft palate and limb malformations are not the classic associations. Example: lithium in pregnancy equals Epstein anomaly. Valproate and carbamazepine equal neural tube defect. Do not mix those up on exam day. Question 12. A pregnant patient stabilized on lithium asks about the major fetal risk. Which answer is best? A. Persistent pulmonary hypertension. B. Neural tube defect. C. Epstein anomaly. D. Microcephaly. The correct answer is C. Epstein anomaly. Rationale. The classic board association for lithium exposure in pregnancy is Epstein anomaly. This is the high-yield fetal risk that the exam commonly tests. PPHN is more associated with SSREs. NTDs are for valproate. Example: when the exam asks pregnant patient on lithium, your brain should immediately say Epstein anomaly. Question 13. Which symptom is a common non-toxic side effect of lithium? A. Coarse tremor with confusion. B. Fine hand tremor. C. Ataxia and slurred speech. D. Seizure. The correct answer is B. Fine hand tremor. Rationale. A fine hand tremor is a common expected side effect of lithium. This is different from a coarse tremor, which suggests toxicity, especially if it occurs with nausea, confusion, or ataxia. Seizures and slurred speech are red flags. Example: fine tremor may be expected. Coarse tremor is concerning. If the tremor looks like it came with a warning label, check the lithium level. Question 14. Which symptom suggests lithium toxicity rather than a routine side effect? A. Mild thirst. B. Fine tremor. C. Ataxia. D. Dry skin. The correct answer is C. Ataxia. Rationale. Ataxia or impaired coordination is a red flag sign of lithium toxicity. Mild thirst and fine tremor can occur with lithium. Dry skin may be related to hypothyroidism, but ataxia suggests neurologic involvement and possible toxicity. Example: lithium toxicity signs include coarse tremor, ataxia, slurred speech, confusion, vomiting, diarrhea, and seizures. If the patient is unsteady, take it seriously. Question 15. A patient taking lithium develops nausea, vomiting, diarrhea, slurred speech, confusion, and coarse tremor. What is the priority action? A. Reassure the patient. B. Administer diphenhydramine. C. Stop lithium and check serum level. D. Continue medication. The correct answer is C. Stop lithium and check serum level. Rationale. These findings are highly concerning for lithium toxicity. Nausea, vomiting, diarrhea, slurred speech, confusion, and coarse tremor are not routine side effects. They are red flags. The priority is to stop lithium and check a serum lithium level. Reassurance or continuing the dose is dangerous. Example: GI symptoms plus neurologic symptoms in a lithium patient equals toxicity until proven otherwise. Let's do a quick recap. Lithium therapeutic range is usually 0.6 to 1.2 milliequivalents per liter. Lithium is a gold standard for acute mania. It reduces suicide risk in bipolar disorder. Before starting, check renal and thyroid function. Lithium exposure in pregnancy is associated with Epstein anomaly. If toxicity is suspected, stop lithium and check the serum level. That is it for today's ANCC PMHNP lithium review. Remember, lithium is high yield because it is effective, but it requires careful monitoring. Thank you for watching. Again, my name is Dr. Ben Osevwe, DNP-PMHNP. For support, you can text 83299165516. Please subscribe to our YouTube channel and join our mentorship family today.